Thank you, Dr. Atul, for the invitation. I'm going to, as Dr. Atul said, I'm going to talk on the surgical intervention for diabetic macular edema. We know diabetic macular edema poses the biggest challenge, management challenge for all of us. And since it is a chronic disease, as we already keep talking about this, so we need a multifactorial sort of approach all the time. So that's very important. So we all know that treatment of DME constitutes so many things, right from metabolic control to focal grid laser, which was a standard of care till, I would say, not now the gold standard, but it is still there. Then intravitreal anti-VEGF and steroids. And of course, what I'm going to talk is a pars plana vitrectomy. And of course, I think combination therapy may be the way to go in most of these cases. How the rationale for pars plana vitrectomy in DME came, there are a lot of studies I have not quoted here, that PVD, once there is a posterior vitreous detachment, it may resolve diabetic macular edema spontaneously. And DME has lower incidence of PVD. We know, most of us, those who deal with this area, there are multiple vitreoretinal adhesions. The complete PVD doesn't occur. So that's where the problem is. So there is release of the abnormal vitreoretinal adhesion with elimination of the bound VEGF may improve DME. That's how it was started. So what are the indications for pars plana vitrectomy in DME? DME with taut hyaloid has absolutely a clear indication, or there is a DME with a vitreomacular retraction. Then we have a lot of epiretinal membranes, vascular, avascular, in cases of diabetics, that form a very major chunk of indication as far as the diabetic macular edema is concerned. And of course, there is a recalcitrant diabetic macular edema without vitreomacular adhesions, which is still a sort of a controversial sort of indication. So we know, as we understand the pathogenesis and with better imaging modalities, the indications for PPV in diabetic macular edema are getting more defined. And we do indicate at this time early pars plana vitrectomy in cases of tractional DME. However, vitreomacular adhesion may not be the primary cause of DME in some eyes. So it's always worthwhile that you should try maybe anti-VEGF before, maybe. That was not the real reason why the diabetic macular edema is there. So I think that's an important issue. And PPV, as I already said, for recalcitrant DME is a controversial subject. So if you have a tractional DME, it will be in many ways it will manifest. So then you need, and you may have something like a focal. We already talked so many things about that. So you need in these cases definitely a surgery. What is very important, I think we must have that. Explain and make patient understand not to have unrealistic expectation of the surgery. This is very important. You must have a dialogue. It's not like doing surgery for a simple epiretinal membrane or so many other things. And the visual prognosis may be variable. The risk-benefit ratio, including the risk of further loss of vision after surgery, should be clearly explained. It may be minor, but still it can happen. And the informed written consent is to be taken. So DME surgery, basically, I think we all started with 20G, which we did for a long time. Most of us, all of us are practically doing 23 and 25 gauge, and even going on to 27. And the pars plana vitrectomy with a posterior hyaloid removal is the basic thing which is required. You need to peel the associated epiretinal membrane. I would say ILM removal is optional and controversial. So we have not really, we don't know whether we should be doing it. And you very rarely need a gas or a gas tamponade, I would say here. Most of the time, if everything has gone well, you don't inject anything. So this is all the way from 2003, the era of 20G vitrectomy. You can see how thick the vitreomacular adhesion is there. So after surgery, you can see just in 6 days, I think you have, again, this one is also from the same era, and you have a thick epiretinal membrane. You remove, and the thickness goes down, the architecture comes back, and that's what happens. So here is a 67-year-old female, 660 vision with a taut posterior hyaloid. Okay, anyway, so I think it started. So this is the case, same case. So here, there is a epiretinal membrane which is being removed. You can use brilliant blue dye, you can use trypan blue, you may not use anything. So it depends what you want to use. And once you have identified this epiretinal membrane, you need to remove this. And most of the time, at least, I'm not one who is removing ILM. Somehow I'll show you a case, because maybe sometimes with your personal experience and no evidence in the literature which is of a sort of a level 1 or 2, so here is a case where the surgery was done and the epiretinal membrane was removed, and you can see just within a period of 3 months, the visual acuity is already 618, and that's what you have a very gratifying result. And this is the OCT. You can see the same thing here. And this is another case. You have a 3x60, looks fairly heavily lasered. This is maybe with the diode laser, where people used to laser them very heavily. And you have a epiretinal membrane, almost like a scetic retina here. So, and very, very poor visual acuity. So here also at 1 week follow-up, we have done partial vitrectomy, and the removal of the vision improved from 360 to 6x36. I think it's very important how well the contour of the fovea would come back. That's what is important. And there's another case here. You can see this particular case required a gas tamponade here. So we have injected SF6 gas, but it does, the contour comes back, the cystic spaces goes away. And still another case, much worse, but it also improves somewhat, and you can see how thick the membrane is there. And this is the case I want to talk. One-eyed lady, other eye was somehow lost somewhere, and I feel very bad about this patient. There's a macular hole also. So I removed the epiretinal membrane, I removed the ILM. And this has already been described also very well. Sometimes you have so much of a thinning of the macular area which happened here. So that's how, probably from your own experience, sometime you do not feel very comfortable that you might have a outcome. This I have just shown in the highly vascularized kind of a case where you are scared. You see those vessels on the top here. It's very important to understand that this is a new vessel. This is not a normal vessel. This is all a new vessel. Even this one, the normal vessel is here. So you need to inject here anti-VEGF, and after injecting anti-VEGF, everything goes up, down. This, you can see, you have to do, I did surgery after 2 days in this case, injecting, because otherwise it would have totally crunched up. And you can see some people are lucky. He was one of them. He's one of the most grateful patients. He's 6'9" at this time. And of course, you should be very careful with these vascular membrane. You may have a crunch like this if the patient was not fit for surgery, and that is what happens in some of. So they should have a fitness before. That's why it's very important. So as far as the DME surgery is concerned, VMT on OCT is not uncommon, but it may not be the primary cause, as I already said. Do try anti-VEGF in some of them. They may work, because it's not that it's only that traction. It may be so both tractional and biochemical components may be playing the role. So trial of pharmacotherapy must be considered. That is what I want to again emphasize in such cases. And DME surgery, as far as DME surgery is concerned, we know it is beneficial for functional and anatomical outcome in tractional DME. I have shown you some of the examples. But the ILM peeling in non-tractional DME, it does improve anatomical outcome, but the visual improvement is very rare. So this is from various studies, including one done by Dr. Atul is also there. And as far as the PPV in non-tractional DME is concerned, it appears to be superior to laser in effects on the retinal structures at 6 months, but no such benefit has been proved at 12 months. So this is from the study here, which has been a meta-analysis. You can see this is a meta-analysis done in Canadian journal recently. So there is no evidence to suggest a superiority of PPV over laser in terms of functional outcome. This is from the various studies and meta-analysis at this time over your standard of care, that is the laser, if you do surgery in a non-tractional. I'm talking of non-tractional DME. So ILM peeling, I already said, it's a controversial subject. Papillofoveal distance is shortened, as according to this publication here last year in IOES, and temporal subfield is thinner on OCT, and I did show you one example, but then it is an individual sort of a thing. We don't have evidence. So PPV has shown beneficial effect And I have shown you cases also in tractional DME. ILM removal is optional and controversial. At present, we are not able to predict which DME would benefit from surgery. That's what is the problem. So there are many studies looking at ILM, looking at ISOS junction or those ellipsoid and other zones, but still we do not have a real answer for that. In future indication for DME, especially as far as the pars plana vitrectomy is concerned, they'll definitely get more defined because we are getting better imaging modalities, and we'll also know which cases should be taken up for surgery. And most of the time, I think it is going to be combined sort of approach, which would help these cases. Thank you very much.